Welcome everyone to the webinar Palliative Care with Dr. Michael Pearl. My name is Savannah Shine. I'm the Ovarian Cancer Program Director at SHARE. SHARE offers many services, including helplines, a telephone and in-person support groups, educational programs. All services are free of charge to participants. If you need more information, please visit our website at www.sharecancersupport.org. I'd like to introduce our speaker now. Dr. Michael Pearl is the professor and director of the Division of Gynecologic Oncology. He's also the director of Women's Cancer Services at Stony Brook Medicine. Thank you, Dr. Pearl.
You're welcome. So good evening, everybody, and thank you for agreeing to spend the next hour with me and Savannah. I hope that what I have to say will be educational and useful for you. So the objectives of my discussion this evening will be to help you define palliative care, to describe the role of palliative care in the contemporary management of the woman with cancer, predominantly gynecologic cancer, since that's what I do. I'll give you several examples of palliative care, and importantly, I will try to distinguish between palliative care and hospice care, since they're frequently confused one for the other, and appraise the New York Palliative Care Information Act. I don't have any disclaimers other than the fact that I occasionally serve as a surgical consultant for Ethicon, and they have no role in this discussion today. So why should we be talking about palliative care at the end, when in reality palliative care should be one of the first discussions that patients should have with their physician? So over the course of the next hour, I will try to answer that question for you. As you'll see, I'm a big believer in humor, and I use a lot of cartoons. Please, if you find any of the cartoons offensive, it's not meant to be so, simply just to illustrate a point in a humorous fashion. So what's palliative care? If you've never heard of it, or if you don't know what it is, you're not the only one that feels that way. As of 2011, the Washington Post did a survey that showed that only a quarter of the women were familiar, or a quarter of people were familiar with that term. I suspect that this was since it was nearly 5 years ago, these numbers have changed substantially. It's definitely not as well known as hospice care, and in fact, most people outside of medicine and many people inside of medicine confuse hospice care with palliative care and vice versa. It's growing quickly, and I again suspect that far more than 59% of the hospitals around the country have palliative care programs. We certainly do, and many, many others. It's cost effective, it improves healthcare outcomes, and patients, once they get involved with palliative care, always like it better. So what is the definition of palliative care? Well, if you go to the dictionary, which is what I did for this, palliative means, as an adjective, relieving pain or alleviating a problem without trying to fix the underlying cause. When it's used as a noun, it is a remedy or medicine, such as palliative medicine or palliative remedies. The traditional view of palliative care, kind of what I grew up with professionally until the last decade or so, is up on your screen. Patients would undergo active treatment, whatever that might be: surgery, chemotherapy, radiation therapy, hormonal therapy for cancer, for whatever period of time. If perchance their treatment failed to control their cancer, then the time came when their physician would say, well, you know, we don't really have much more that we can do for you, so we're going to do some palliative care. And then that portion of treatment would last until the individual passed away, and that was the end of it. Even in the medical literature, this is, at least it was, the general sense of palliative care. So here's a quote from an article in one of my journals that I read. Recurrent ovarian cancer is seldom curable. The seldom curable is bolded and underlined, and that's mine, not theirs. Second, third, or even fourth line chemotherapy is often administered in a palliative fashion as a means of diminishing symptoms and prolonging life. So that fit in very clearly with the traditional view of palliative care. So let me give you a hypothetical, made-up example of a somewhat classic patient in my practice. So Miss Jones has stage 3C epithelial ovarian cancer, most common stage, most common type of cancer. She undergoes cytoreductive surgery or debulking surgery, followed by standard chemotherapy with Taxol and carboplatin. Unfortunately, she has a recurrence that is treated with topotecan. Her cancer progresses and her chemotherapy is switched to Doxil. Her cancer progresses again and she's switched to gemcitabine and cisplatin. Soon afterwards, she develops a small bowel obstruction and undergoes surgery that is unsuccessful at relieving her obstruction. She has postoperative and abdominal pain related to her obstruction. She becomes progressively weak, develops altered mental status from fluid and electrolyte abnormalities, and 9 days before she dies, she's admitted to hospice. She lives approximately 43 months from her diagnosis. The contemporary view of palliative care is quite different than the traditional view, and here's an example. So in the contemporary view of palliative care is given or used or utilized concomitantly with other treatments that are directed towards life prolongation or hopefully cure. But what happens over time is that the ratio or the percentage of effort that is administered by life-prolonging or curative treatment varies, and as that treatment or that approach to treatment decreases, the palliative care or comfort intent treatment increases. Ultimately, the patient passes away, and the palliative care team then works very closely with the family and, if need be, the friends for a bereavement process that lasts as long as is necessary. CMS is the governmental agency that oversees Medicare and Medicaid, and so dictates much of the management of healthcare in the United States, and certainly dictates how healthcare is paid. So a number of years ago, CMS agreed to pay for hospice care in the United States and also to pay for palliative care. In order to do that, they had to have a definition of what is palliative care. And this is the definition, and this is actually a very good definition. So palliative care means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care, again, bolded and underlined by me, not by them. Palliative care throughout the continuum of illness involves addressing all the needs of the individual, physical, emotional, intellectual, social, spiritual, and the goal is to facilitate maintaining patient autonomy, continued access to information, and to support patient choice. So let's go back to our hypothetical patient, Miss Jones, and look at her now under the auspices of the contemporary view of palliative care. So Miss Jones, as we indicated earlier, has stage 3C epithelial cancer of the ovary. She undergoes cytoreductive surgery, followed by standard platinum and Taxol chemotherapy, just as she did before. But this time, before she is discharged from the hospital, she is referred to and seen by the palliative care team. It's led by a palliative care physician. There's a clinical pharmacist, a social worker, an attorney, because you can't get through life without some sort of legal help, an occupational therapist, a beautician, nutritionist, and a chaplain. She unfortunately has her cancer recur, and she is started on treatment with topotecan. But before she is started on treatment, she is referred back to the palliative care team and undergoes an evaluation by them. As she goes through her treatment with topotecan, her cancer ultimately progresses, and she is treated with Doxil. The palliative care team is involved actively with her care during this time. When her cancer progresses yet again, after discussion and involvement with the palliative care team, her chemotherapy is stopped. She too develops a small bowel obstruction, but unlike the first Mrs. Jones, she does not undergo surgery. She has a gastrostomy tube placed for drainage and comfort care. She is enrolled in outpatient hospice. Her pain and her other symptoms are very well controlled, and she dies at home comfortably in peace, surrounded by her family and her friends 5 weeks later, and she lives 49 months from her diagnosis as opposed to the 43 months that the first example of Miss Jones lived. So as you saw in the previous slide, and you just heard in my discussion of the previous slide, I used two terms, palliative care and hospice care. And these two terms are frequently exchanged for each other or misinterpreted one for the other, or used when kind of as a global description of either one. And most people, since they've heard of hospice more often than palliation, use hospice care. But they're very, very different. Palliative care is treatment that can be given at the same time and in addition to life-prolonging treatment. It's appropriate anytime during the management of any serious illness. There's no prognostic requirements, meaning that the physician or healthcare provider doesn't have to say that, well, you know, you got 6 months left. And there's no need to choose between the management approaches, meaning palliative care or curative or life-prolonging care. Anytime, in all honesty, anytime you have surgery, you get some palliative care because you get pain medication after your surgery, for example. Hospice care is a subset of palliative care that provides care for those individuals at the end of their life, and I'll discuss that in a moment. The general public perception that a hospice is only valid in the last 6 months is incorrect, and it came about because CMS, when they were debating whether or not to pay for palliative and hospice care, decided that there had to be a time limit on it. They did not want to pay for palliative, or did not want to pay for hospice care. See, I do it too. They did not want to pay for hospice care on an indefinite basis. So after a fairly extensive negotiation process, they settled on 6 months. Patients must have 2 physicians certify that to the best of their ability to do so, they believe that the patient has less than 6 months to live. In addition, if the individual patient is on Medicare, they have to give up their insurance coverage for curative or life-prolonging treatment for that disease in order to be eligible for hospice care. It does not mean giving up Medicare altogether, it just changes it around. So for example, if somebody has end-stage cancer but is otherwise doing well and happens to fall on the ice and break his or her hip, just because they happen to be in hospice doesn't mean that treatment for their hip fracture would not be given. It would be. But if they have decided to enroll in hospice, they cannot get chemotherapy directed at their cancer while they're in hospice, for example. So hospice and palliative medicine is now a nationally recognized subspecialty with board certification available through a variety of the American boards. For example, in my subspecialty, we have the opportunity to become board certified through the American Board of Obstetrics and Gynecology, and I and approximately 29 or 30 of my gynecologic oncologists colleagues have taken the opportunity to become board certified as a hospice and palliative medicine specialist. There are hundreds, if not thousands now, of HPM board certified physicians across the country in a variety of different specialties. So the palliative care model is evolving, and this is a reasonable pictorial representation of what palliative care as it exists now is viewed, or how it's viewed. So under the umbrella of broad-based psychosocial and spiritual support, palliative care is given in conjunction with disease-focused care. And the only thing that changes over time is the relationship or the ratio between palliative care and disease-focused care. If perchance the disease is ultimately fatal, then there is a follow-up period of time with the family or the friends or both. So the palliative care team is usually a team. Here at Stony Brook, we have a palliative care team that is led by 2 palliative care board-certified specialists. Those are not me. I'm part of the team, but we have a palliative care specialist whose only job is that. I'm a gynecologic oncologist, so I'm still a practicing physician as a cancer physician in addition to my palliative care role. So it's usually led by a palliative care physician and includes nurses, social workers, chaplains, pharmacists, nutritionists, massage therapists, attorneys, so on and so forth. And their overall goal is listed here. It's to maintain communication, certainly within and amongst the team and with the patient and the family, to provide expert management of pain and other symptoms, to help individuals navigate the highly complex healthcare system that we work within, to provide guidance with difficult and complex treatment choices, and this is becoming ever more important as treatment becomes ever more complex, and to provide emotional, spiritual, and other forms of support for the patient and his or her family. While it seems like we offer a very broad range of services, the goals are very specific and very concrete, and generally can be summarized as helping relieve suffering and maintaining dignity. So we treat pain and other such distressing symptoms, nausea, vomiting, difficulty with sleep, constipation, diarrhea, just about anything. We provide psychological and spiritual care regardless of one's spiritual beliefs. We try very hard to accommodate everybody. We provide a support system that will help patients live as actively as possible for as long as possible, and then once they pass away, if they pass away, we have a support system to help sustain and rehabilitate the patient's families. So here's some examples. Some of these we have, some of these we don't. We do have a clinical pharmacist. She, on the Gynecologic Oncology service, since we do chemotherapy and surgery, she runs our chemotherapy program. So the physicians make the decision about which chemotherapy to use, oftentimes in consultation with her, and then she writes our orders. We review and sign the orders, and then she does all the symptom management as the patients go through their treatment. We have a social worker assigned to the cancer center and another one who works with the palliative care service who help individuals deal with such issues as advance directives and getting access to the community resources through a variety of services, through a variety of sources. We have an attorney who volunteers her time to help individuals with the myriad legal matters that come up, some of which are very straightforward and easily handled, some of which are extremely complicated. We have a variety of spiritual advisors available. Pretty much we can cover just about any individual's spiritual beliefs regardless of what they are. Although we don't have a massage therapist or cosmetician on the team, we have very close relationships with the commercial groups, commercial programs out in the community, many of whom have graciously and lovingly provided their services for free to our patients. So if somebody needs a cosmetician or a beautician as they're going through their treatment, we have programs like Look Good, Feel Good, and then individuals in various businesses around the community will volunteer their services. We do have an acupuncturist on staff who's available for patients and staff, by the way. Our nurses and some of the physicians use him. We have a physical therapist, and we have a cancer-related nutritionist who works very closely with us. So why palliative care? I've told you a lot about what it is, but why should we bother with palliative care? What benefit is it to individuals, to the community, to the healthcare system? It is beneficial, and it's been shown that patient satisfaction is markedly superior when you compare palliative care to the usual care. The degree of care and the setting of care is more concordant with patient preference when palliative care is involved. There's a greater support emotionally, spiritually. There is certainly better communication and a better understanding of the information that is available. There is greater care at the time of leading up to death and the time of death. It provides greater access to community services. It is sometimes very complicated to figure out what is available out there, especially when somebody is recently diagnosed or dealing with a very complicated disease. It helps maintain individuals' well-being and dignity. It provides a tremendous improvement in not just pain control but other symptoms. And then for the families and friends, it helps with bereavement, which is otherwise a form of post-traumatic stress disorder. It's beneficial for the individuals. This is just one of many studies that are out there. This study looked at 300 plus seriously ill cancer patients, and what the authors found, was that if at any point the patient or the family could recall a conversation with their healthcare provider that discussed goals and prognostication, if at any point during the time of their disease they could recall that conversation, they ultimately had a better quality of death and dying, and there were descriptions about what quality was, or how it was defined. There was a lower risk in the family of complicated grief and bereavement. There was less aggressive care, and there was lower costs of care. Doesn't mean that giving less care, less aggressive care, or giving less expensive care means that patients are going to go through death panels or they're not going to live as long. In fact, the opposite is true. This study was in lung cancer patients. Cancer is one of the most lethal of the cancers that we're dealing with now. It's becoming ever more common because of smoking and other exposures, and the mortality, meaning the death rate associated with lung cancer, is approximately 70%, which is right about the same as the mortality associated with cancer of the ovary. There's just many, many, many more individuals with lung cancer. So when this study came out, it created a big splash all the way across the country, and many newspapers and other lay press picked it up, and it was all over the place everywhere. And I remember a New York Times headline with this article. So the individuals performed a randomized prospective controlled trial. That's the gold standard of clinical trials for patients with newly diagnosed non-small cell lung cancer. And the only thing that they did different between the two groups was one group had the opportunity to work with an integrated palliative care team. The other group had standard cancer care, as did the first team. First group had standard cancer care that was exactly the same as the second, just they had the palliative care service involved. So the palliative care team met with the patient and the family within 3 weeks of the diagnosis, and then at least every 6 weeks subsequently. They underwent pain and symptom management, psychosocial and spiritual support, assistance with treatment choices, help in planning for care, and bereavement support and referral, all the things that I've discussed with you already. And when the study was finally finished and the data were analyzed, to the authors, to everybody's surprise, but not the authors, because they kind of knew what was coming, it was found that early palliative care led to better quality of life, and this is what hit the news, was that despite the fact that the individuals in the palliative care group chose to undergo less aggressive care, they lived substantially and statistically significantly longer, 11.6 versus 8.9 months. While that might not seem a lot, that's a tremendous change without direct treatment or treatment directed at their cancer. So this created a big buzz all over the country, as it still does. I still go around and hear about this study. And yes, palliative care reduces costs, and that's a very important issue these days as medical costs become an ever-increasing topic of discussion. There are substantial data that demonstrates decreased costs across basically every setting, all regions, institutional delivery models. Why? Well, it's very clear that if patients' families, their physicians, and other healthcare providers are able to speak openly and realistically, ultimately what happens is the patients make more conservative conservative choices. It allows provision of higher quality and generally more satisfactory care in generally more appropriate and often less costly settings. And as we saw in the previous slide about the previous study, patients are actually living longer with palliative care than less. And yes, as we discussed earlier, palliative care includes hospice as a subset. So when individuals are asked what is their definition of a good death, there are some common themes that come out. It is not this: dying intubated in an intensive care unit surrounded by multiple machines and a sterile, completely impersonal, unpleasant, and uncomfortable environment. It is not even really this, in all honesty, although I like the right to die without dignity. The themes that come through is people want to die at home, surrounded by their family, their friends. They want to die comfortably without suffering, however one wishes to define suffering. It is important to have a sense of completion, the opportunity to say goodbye to those important to you, as well as an opportunity to have reviewed one's life and the accomplishments of one's life. In palliative care, including hospice care, allows people to die at home. Somehow or another, this slide over here, some of the things that I had in here didn't show up. So let me run it through. So this looks at data for patients who have either congestive heart failure, chronic obstructive pulmonary disease or emphysema, or cancer, who anywhere in their record had evidence that they received palliative care, and those that did not receive palliative care. And those this is the standard care, this is palliative care. And over a 10-year period, or over a 1-year period, sorry, those individuals who had palliative care involved in their treatment were far more likely to die at home than they were to die in a healthcare facility. So those of you who are here in New York, I don't know if everybody's in New York, but those of you who are here in New York, you need to know the following. Some years ago, maybe 5 or 6 years ago, New York passed, the New York State Legislature passed what became known as the New York Palliative Care Information Act. Now, it's really a lousy name because if you read it, if you actually read the act very carefully, generally what they're discussing is hospice, not just palliative care. Typically, they're talking about hospice. Patients diagnosed with a terminal illness or condition. We can talk about palliative care and end-of-life options, so on and so forth. So I'll leave this here for a second, and then I'm going to go through some of the bits and pieces. But the thing to understand about this, and what I try to get across to the healthcare providers that I speak to professionally, is that this is a law. This is not optional. This is a law. And like most laws, there are teeth attached to failing to follow the law. So if you have a terminal illness or a life-limiting illness, such as a serious cancer, congestive heart failure, chronic obstructive pulmonary disease, a neuromuscular disorder, there's a variety of potentially life-limiting or life-ending diseases, it is the law that your attending healthcare practitioner, whether that's a physician, a physician's assistant, a nurse practitioner, any variation thereof, that individual has to offer to provide you with information and counseling regarding palliative care and end-of-life options. And really what they're talking about in this setting is hospice care and end-of-life options. It can be given either verbally or in writing, and they have to give the information to a healthcare proxy if the individual, the patient, has the inability to reasonably understand and make their own decisions. If the healthcare provider is uncomfortable with doing that, they can make arrangements for that to be done by other professionally qualified individuals, so you can send the individual out for a consult. but it has to be done. So what are the pitfalls with this? Well, here's the first. If the patient is diagnosed, and again the bold is my highlighting, with a terminal illness or condition, blah, 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 blah. So this is specific for patients who are predicted to have less than 6 months to live, i.e. they're terminal. It requires that a physician be able and willing to make the prediction, which is prognosticate. And the wording, as I've tried to get you away from over the first portion of this discussion, suggests that palliative care and hospice care are identical, and that's not the case. Hospice care is simply a subset of palliative care, but the New York Palliative Care Act really should have been named the New York Hospice Care Act. So what are the components of end of life? I've talked about that a little bit. How do you know when an individual is at the end of life? So the National Institutes of Health had a State of the Science conference about a decade ago, and they came up with the following definition. So these are the smartest of the smarts who said that the end of life, components of end of life, is the presence of chronic disease or diseases, symptoms or functional impairments that persist but may also fluctuate. And these symptoms or impairments resulting from the underlying irreversible disease require formal or informal care and can lead to death. And unlike CMS, the NIH did not include a time component. So the reality is, if you take a step back and you look at this with a different viewpoint, really what they're defining is not the end of life, they're defining life, because all of these factors affect all of us as we go through our lives. And since it does not have a time component, guess what? This starts at birth. There is no crystal ball. Despite having a new high-definition model, there's no crystal ball, and I quote this study on a regular basis. So this was done in Britain, where modern hospice was reborn in Britain, and they have a much longer history of having hospice and good hospice than we do. We're catching up, but they're really far ahead of us. So this study was a very savvy, very easy, very straightforward study to do. So they looked at 233 cancer patients who were enrolled in hospice at the onset of the terminal phase of their disease. And when the patients came in to enroll in hospice, or when they enrolled in hospice, they asked the physicians who were responsible for their hospice care to estimate how long that particular patient would live. So they took patient 1 and they said 5 months. They took patient 2 and said 7 months. They took patient 3 and said 3 months. And they wrote all these estimates down. And then they just simply waited. These were all terminally ill individuals, and they all died. And when they passed away, they wrote down how long they had lived. And then they compared the physician's estimates to the actual length of life. And what did they find? Well, they defined accurate as plus or minus a month. So if the physician said 5 months and the patient died at 6 months, that was accurate. If the physician said 5 months and the patient died at 4 months, that was accurate. So it gave them a 2-month range in which they were considered accurate. Anything above or below that was considered inaccurate. So 25% of the time, the physician was accurate plus or minus a month. About 25% of the time, the patients underestimated the survival. And these are the ones that we always hear about. Somebody comes into the office and said, you know, my uncle was told that he had 3 months to live, and that was 7 months ago, and he's still down in Atlantic City hooting it up. So we hear all about those. Half the time, or 2/3 of the incorrect estimates, the physician overestimated the survival. So they said, well, you know, I think Mrs. Jones has 6 months to live, and she passes away in 3 months. And we never, ever hear about those. So palliative care, I hope you realize by now, is more than just hospice care. I threw up the contemporary view as well as the traditional view so that you can compare and contrast. In the traditional view, active treatment is given by itself until such time as the individual is told there's no more treatment available for your cancer, for example, and now we're to institute palliative care, which really in this setting is more precisely defined as hospice care, and then the person passes away, and that's the end. In the contemporary view, palliative care and life-prolonging or curative treatment are given simultaneously, and there is no reason not to do them both at the same time. If perchance treatment is unsuccessful and fails, and the patient passes away, then there's a bereavement process at the end for those who are left behind. The Palliative Care Information Act also says if you can't do it yourself, you can ask somebody else to do it for you. Right? And like I said, there's cartoons about this. So this is what you don't want. How to break the news to a terminal patient. You have a terminal illness, you're going to die, thank you for calling. You need somebody who is comfortable at discussing, and I'm just going to go back, this is not really talking about palliative care, even though the act is described as Palliative Care Act, they're talking about hospice. Palliative care, how can you get true palliative care? Well, the very first thing to do, and you should do it, is to ask your healthcare provider, whether it's a physician, a PA, a nurse practitioner, or any other type of provider. You can ask, and you should ask. And if they say, I don't know, then ask them to help you find out, or look elsewhere. You can call whichever hospital you might be associated with. Most hospitals nowadays have a formal palliative care service, or at least an informal relationship with some of the palliative care specialists to provide true palliative care. There is tremendous discussion amongst patients, and the opportunity to do so has increased exponentially as different forms of communication have become available. This webinar is a good example of something that didn't exist 15 years ago. So speak to other patients. I generally don't go down to my chemotherapy suite in my cancer center simply because the patients are talking about me and they're talking to each other, and I don't want to interfere with that. And then there's a variety of resources available over the internet that I'll show you in just a second, and then I'll leave that up at the very end so that you can either take a picture, modern way of doing it, or write it down. So there are a variety of ways to get resources. So these are some of them. My professional organization for hospice and palliative medicine is the American Association. They're readily available at www.aahpm.org. They have a tremendous amount of resources available for healthcare providers and the public. CAPC, C-A-P-C, is a center to advance palliative care. They're based in New York City, and they have also an almost limitless amount of resources available. National Hospice and Palliative Care Organization, their website is there, and then there's a variety of other ones, and I just listed a few that come up easily when you do a Google search or any other search and you write in palliative care. You will get millions upon millions upon millions of hits. So there are many, many ways to get resources, both online and in the traditional fashion. So that's about all I have to say. Plenty of time for questions because many times that's where much more information comes back. So thank you for your time and your attention. And let me go back to my slide that lists the palliative care resources, and I'll leave that up while we chat.
Thank you so much, Dr. Pearl. That was a great presentation. I loved your use of cartoons and images.
Thank you.
So I want to invite everybody in the audience, if you have questions, to please submit them. And I see one coming in, and then I have a few that were submitted in advance. So I'm going to ask the couple that I have in advance, and then I'll give you guys a couple minutes to submit some. Some women in prolonged treatment for advanced cancer suffer from anxiety and depression prior to their diagnosis. When anxiety and depression become overwhelming, Dr. Pearl, what do you suggest?
Well, the very first thing is to make sure that you're healthcare provider knows. The worst thing to do is to try to hide it and suffer in silence, so to speak. We, in my institution, we're very fortunate in that within the last year, we hired a psychiatrist with specific formal training in oncology issues. So I'm not really sure whether she's an oncopsychologist or a psycho-oncologist. I think probably the former is what she prefers rather than be called a psycho-oncologist. But there are specialists in mental health issues that should be readily available once you speak to your healthcare provider, and try not to suffer in silence. I personally believe that if somebody isn't having mental health issues, meaning anxiety, depression, stress, if they're not suffering from that, I personally think that there's something going wrong. Because generally, if somebody has an advanced cancer, it is a life-threatening at the very best, and most often a life-limiting disease. And there's no way that that can't be stressful, or there's no way that they can't produce depression or anxiety. So don't suffer in silence. Speak up, say something. And if your physician or healthcare provider doesn't provide you with the adequate response or the appropriate referral, go elsewhere.
Thank you. If you decide to stop treatment and go into hospice, can you change your mind?
Yes. As a matter of fact, you can, and that's a very good question. So that most people don't bring that one up, but the answer to that is yes. You can go in and out. There are rules about that that are probably beyond the scope of this discussion. But yes, you can opt out of hospice for a period of time and then opt back in. You can't do it frequently, and in reality, you probably shouldn't do it. If you're at a point where hospice is appropriate, generally you don't get better where hospice is no longer appropriate. But there are times where one has to come out of hospice, for example. Remember my example of the individual who was in hospice who fell down and broke her hip. Officially, if that person is brought to the hospital and chooses to undergo either some sort of orthopedic procedure, placing a pin, placing a rod, having a hip replacement for management of their fractured hip, during the interval they're off hospice. So then you restart hospice when the person leaves the hospital. If you're going to enroll in hospice, start, and then a month later say, you know, I feel really well and I don't want hospice anymore, you have the opportunity to opt out. There are some issues with relation to the insurance coverage and getting back into hospice, but it doesn't mean that once you're out you can't go back in. So the answer to that is yes, you can do it. If you're going to do it, you need to speak very carefully to the supervising hospice physician about how to do it and what the implications are with regards to insurance coverage.
Okay. Why don't oncologists regularly refer their patients early for palliative care?
That's a really good question. I think that there's a couple of reasons. One is practical. This is a relatively new service that's available, and many places, as of yet, still don't have a well-developed palliative care service. For example, at my institution, as much as I love working here, we have a great palliative care service for inpatients. So if you happen to be admitted to the hospital and you need a palliative care team, we've got one of the best. If perchance you're an outpatient, which most of the patients are, and you need a palliative care service, I'm so sorry we don't have one. We have all the components, and so we do provide palliative care, but I don't have a palliative care team on an outpatient basis. And despite more than several years of arguing and discussing and begging with the administration, they're not willing to provide the resources necessary to establish a team, even though we've shown them data that it's cost effective and they'll ultimately save money. So that's one reason. One is that it's just not readily available. And the second is because it's a relatively new process, many oncologists, as they went through their training, especially if they're out in training for more than a decade, let's say, they weren't trained with this. The physicians that are coming out now in the last decade, who finished their training in the last decade, those individuals probably went through their training with palliative care services, and so they're used to having palliative care services around. The older ones, unless they've made the effort, just aren't aware of it, and so they're not as likely to provide a referral for a palliative care service. And then if you get out of the cancer world, then it's even less. The physicians that treat cardiac disease or pulmonary disease or neuromuscular disorders or the degenerative brain diseases like Alzheimer's, they're just not as familiar and comfortable with using palliative care services.
Got it. Can you address the use of palliative care for patients in clinical trials?
Oh, well, you know what? That's an interesting question. I got to think about that for a second. I wear many hats at Stony Brook. I'm a practicing gynecologic oncologist, so I have a busy practice. I direct my division. I run the gynecologic oncology service for the hospital. For the cancer center, I'm the director of women's cancer services. But on top of that, I happen to be the chairman of the institutional review board, one of the two of them, that's responsible for overseeing all human subjects research in this institution. So I wear both hats, all three hats. I'm a clinician, a researcher, and a research reviewer from a human subject standpoint. So the question is interesting. There is no reason that somebody in a clinical trial shouldn't have access to palliative care. Most clinical trials have fairly strict and fairly regimented protocols. So you can do this, you can't do that, this is okay, that's not okay. But generally they don't restrict the support services. So if somebody is in a clinical trial for a certain type of a chemotherapy drug, they may dictate, in many of the trials that I'm involved with, will dictate what type of anti-nausea drug is used. They'll give you a spectrum of them, but they may not dictate what somebody could get for pain medication, for example. So it shouldn't, if somebody's in a clinical trial, it shouldn't prohibit them from at least being involved with palliative care. It may confine or constrict or define some of the options, but it shouldn't eliminate the possibility. That's a really remarkable question.
Yes, we get great questions from our audience. Another one. While I don't want to be in pain if my cancer advances, I don't want to be so doped up that I can't talk with my friends and family. Is that possible?
Sometimes, sometimes not. And that's the blunt, honest answer. That yes, in general, one can achieve pain control sufficient for an individual's needs without having somebody so dopey that they are laying in bed completely stoned and unaware of anything. It may be that when pain medication is first initiated or when the dose is changed substantially, that there's a period where the person may feel doped up or stoned, whatever term you wish to use. But generally, tolerance kicks in pretty fast, and those symptoms or those side effects of the narcotics will dissipate pretty fast, leaving the pain relief behind to still be effective. Having said that, there are times, unfortunately there still are times, where in order to achieve adequate pain control to make the person comfortable, they're loopy. And sometimes they're loopy enough that they're absolutely, they're utterly and completely stoned and unable to have any meaningful communication with anybody around them. That's rare, few and far between, and usually is something that would occur at the very end of an individual's life. Pain control is one of those things that should be achievable for just about everybody. I tell my patients that there's not a lot that I can guarantee. There are a few things that I can guarantee. One is that as long as they want me, I will be involved in their care, that we will never abandon them, and that I guarantee. I will generally guarantee, with a little bit of a caveat, I tell them that as long as you're willing to work with me, I can reasonably guarantee that you won't have pain. It may take a lot of work, and they may not like some of the side effects associated with it, but usually we can keep their pain control.
Is there
Sure.
any training for doctors to keep up the education?
In palliative care?
I'm assuming that's yes.
Yeah, I assume so too. That's a really good
Yes.
question, and
Yes.
and very timely. So the general answer to that is yes. That if you start at the board level, at the American boards of whatever program one might be in, almost all the boards have, it's called a maintenance of certification program that includes continuing education. And the continuing education component is mandatory for maintenance of certification. So the quick and easy answer to that is yes. There are a variety of educational meetings. The American Association of Hospice and Palliative Medicine is the main one, and they have an annual plus some individual meetings, but they have an annual meeting. It's actually coming up soon in March this year in Chicago. Some of the sessions, in all honesty, are open to the community. They're not just physician or healthcare provider based. So that was a long-winded answer to a short question, but yes.
Great. Okay, at this time we're going to wrap up. I want to really thank you again, Dr. Pearl, for this great presentation, and to the audience again.
My pleasure. Everybody have a good evening.
All right, you too. Thank you so much.
All right. Bye-bye.